Thanks for being here. So this is one of our regular lunch talks. We'll be hearing about patient-discharge decisions and how doctors can, I guess, make more informed ones or better ones. I guess without further ado, thanks for being here and thanks for talking to us. And so, yeah.
Start the slideshow. There we go. Oops, sorry. Okay, so this is one of actually several different research programs I have running simultaneously. It's the way I usually approach things. I just like to work in many different areas. And they're in very, very diverse topic areas. This is one of two areas where a group of experimental economists at my center, the Experimental Economics Center at Georgia State, are working with surgeons at Emory University Medical School. And there are two of those areas where we're working with the surgeons. One of them is working with transplant surgeons and decision making about when to accept and reject human organs available for transplantation. The area I'm talking about today is joint work with GI surgeons, and the topic is the hospital discharge decision, which is a very, very important decision. It's a critical decision that affects both quality and cost, and it's one where it's recognized as being one where it's not being made well now, to the extent that Medicare has instituted a national program of fines to hospitals for excess readmissions. And these fines are already large and they're escalating and spreading to broader areas. So this is a case where it's recognized that this is a type of decision making that needs to be improved, both to keep costs contained, but also to lower the readmission rate, because unplanned readmissions are a sign of low quality, and once it happens, then it escalates costs. So this is the area where we're working. The collaborators, as you see listed there, Vyolta Sidirai. There will be a test at the end whether you can pronounce my colleague's name correctly. Vyolta Sidirai, who's in the Experimental Economics Center. Kurt Schneer, who was until recently, when he moved to UC Merced, he was with us when we did this work. And John Sweeney, who's head of the surgery department at Emory University Hospital, Emory University Medical School. This is work financed by an NIH grant. It's now in press. Okay, so the background, I said a little bit about this already, is that Centers for Medicare and Medicaid Services, or CMS, is penalizing hospitals now for high unplanned readmission rates. Most recently announced penalties are estimated to cost hospitals $420 million starting in October 2015, and they're escalating after that in later years. And most recent ones we could find in 2010, more than 19% of Medicare patients were readmitted within 30 days, and I'm talking about unplanned readmissions. The additional charges were $17.5 billion. So this is starting to be real money that's involved in this. And our topic is to develop a clinical decision support system known as CDSS that can decrease 30-day readmission rates and/or decrease average length of stay. In other words, as in the title of the paper, we're seeking higher quality at lower cost.
Jim, just to clarify, readmitted here means for the same
diagnosis code and not planned. Yeah.
So it's not just that the same individual's coming back.
No, same diagnosis code.
Okay.
Yeah. Thank you for that. That's very good clarification. Now, one question that comes up immediately, of course, was, well, why should economists be involved in this? And especially, why should experimental economists be involved in this? Well, experimental economists, we are experts in decision. Some of us are. That's one of my areas of specialization. And experts in use of information. And experts in mechanism design. All the sorts of things that you need to improve medical decision making, because the problem is not lack of information, it's lack of the ability to use that information and to use it well. This is what we do. This is what our expertise. So it's a natural partnership. And you look at the current practice, and this is not my description. This is a description of our surgeon colleague about current practice. In discharging a patient, the physician examines the patient, of course, reviews the electronic medical records, or EMR as they call them, I sometimes say EMR, decides whether to discharge the patient on largely subjective criteria. Based on what? The recall of the doctor's own medical education, recall of own previous practice, and perhaps consultation with a colleague. That is an extremely limited evidence base on which to make that decision. Compared to what? Compared to the information that's potentially available from the electronic medical records for a patient population of a large hospital. Emory University Hospital has about 25,000 patients per year. So the idea is to use the information from that huge patient population and bring that information to bear on each discharge decision. Well, obviously that's not something that the human mind of the doctor can do. It requires the creation of a very specialized IT product, in this case a CDSS, that can be brought to bear on the point of care. So that's what we're doing. Yeah.
Are there any restrictions with HIPAA in terms of using, obviously it's anonymized, but personal medical records? What are the rules there? 'Cause I know, like,
They're very stringent, but we're applying all of them. We're applying what's called the HIPAA Safe Harbor Standard is what we're applying.
So are you able to use the sort of the universe of data that Emory has, or do you have?
Yes.
Okay.
At Emory it's called the data warehouse, which is where all the electronic medical records go out of the electronic system. And we have people that are inside the firewall that extract the data for us, de-anonymize it, anonymize it, yeah, and send it to us. Okay. And essentially, all they need to remove are the patient's name and address, because it's such a large number. Yeah. Yeah. Oh yeah, believe me, yes, we're implementing those. Otherwise, it's electronic medical records data. Okay, so the research protocol: extract a large sample of de-identified patient data from the data warehouse, develop a predictive model of 30-day readmission. In other words, if you can identify the characteristics of patients that have been discharged and it's been unsuccessful. When I say unsuccessful, I mean the Medicare standard. The patient is readmitted in an unplanned readmission with the same diagnosis code within 30 days. Okay. And if we can develop a model that can distinguish between successful and unsuccessful discharges and what the differences, the patterns in the electronic medical records, then we can have something that can be used to help to solve their problem. So the first stage is to develop a predictive model of 30-day readmission and develop a first or alpha version of the CDSS based on the model's predictions, conduct laboratory experiments to test uptake of the alpha CDSS under alternative information and compensation treatments, and then if the lab tests look good, then go on to develop the beta version of the CDS that can interact with electronic medical records in real time, and then take it out onto the hospital wards, which is, of course, the real final test. Now, of course, for both ethical and practical reasons, you have to do laboratory tests of the system before you take it out onto the hospital wards. this is the same if you're testing a drug. You don't immediately test it in the general population. You do control tests. The current stage of the research is we have completed a long series of laboratory experiments. We've either published or have in press various papers. One that's in press is the one I'm talking about today. We've been stalled in the next steps of developing the beta version and getting out on the hospital wards, because now we require the detailed cooperation of the IT department at Emory University Hospital and of Cerner, which is a company that provides electronic medical records to Emory. And when we require that kind of cooperation, you start to run into long, long, long delays. One of the things we're interested in pursuing now is looking for other partner institutions. And I was hoping there might be people here from Alaskan health systems, native people's health systems, like, or anybody. None of them made it. Okay. Okay, too bad. All right, okay, so, all right. Present status of the project, I said a little bit about this. We have a couple of preliminary papers, the top two here that were published in medical journals, and we're aiming to both publish in medical journals and in economics journals. And believe me, that is no small feat, because you can't believe the difference in culture between these two disciplines. And you sent something written as you'd send it to an economics journal, and the editor would just insult you, and to a medical journal, the editor will insult you, and vice versa. But we think it's important to do that. And the other thing is, once you also have another very different culture, which is when you're writing papers that are going to medical journals. I have a standing joke that I tell there, very different than economics, about it. A lot of these medical journal papers, a very large proportion, have more authors than they do pages. And the reason is they just, we figure a co-author ought to earn. And so I have a standing joke. I see you're at the medical school, you're sitting in your office, and you're talking to one of your co-authors about your paper, and the office door is open, and somebody walks by in the hall and says, "Good morning," and you then add them as a co-author. So that's almost like, not quite like that, but. So you see that we have an overlap in those top two papers with the bottom two. The experiments with the CDSS are reported in two papers that are in press at GBO. In this case, all of the authors actually contributed to the research. Okay, the economics approach. Okay, present status of the project. We see we've got forthcoming papers on the laboratory testing of the CDSS. And we're continuing to extract more and more patient data from the data warehouse at Emory. And we've now, the econometric model in this paper I'm talking about, we used data from about 3,200 patients. In the continuing work now in developing the we're up well over 20,000 patients now. So we're really starting to get big data behind this. And the development of the beta CDSS, it's in planning. Okay. So here's now a specific paper model I'm talking about today. This is our very first econometric analysis, 3,202 patients. They're GI surgery patients from 2007 to 2009. The data consists of vital signs, lab tests, nursing data, medications, imaging, diet, transfusions, medical history, and socioeconomic data, a little bit of which we could get from the EMR. We got the rest of it by, we could not violate HIPAA if people inside the firewall could link up the addresses with zip codes. And so then we use census data to get some additional data. We use a probit model to estimate probability of readmission within 30 days. And these are day-specific estimates of the readmission probability conditional on the patient's clinical and demographic data. Now, what we're doing here is something that's very, very different. If you just do a Google search looking for people that claim to have software to be used in hospital discharge decisions, you'll find a lot of stuff there. But what this is completely different than what we're doing. What they're doing is they're simply looking for diagnosis codes, comorbidities, and things that means these types of patients are more likely to be readmitted, and you can plug that in when your patient is admitted to the hospital. What we're doing is just way different than that. What we're looking at, we have all that information, but we're looking at how all of this data about the patient, how it changes from day to day, and actually on 8-hour intervals, and how it evolves while the patient's in the hospital, and how those changing conditions, this model is dynamically updated, because that's what you need to know when it's time to discharge that particular patient. That's the question you need to solve, not just know whether some types of diagnosis codes and people who have cancer or don't are more likely to be readmitted. Yeah.
So do you think the model here is kind of product outcome of data mining, machine learning?
Well, we're obviously mining data.
Kind of data mining model or machine learning?
No, it's a dynamically updated probit model.
But yeah, so in statistical and computer science, this kind of dynamic model building is actually data mining or machine learning. So that the results involve of human subjective judgment, and there is no human involvement in the dynamic modeling process, and it's all based on the accumulated huge amount of patient data.
You can look at it in that way, yes,
Okay.
but you got to keep in mind that the input into the data is being generated by humans. So our question is, we're trying to provide humans with a better way of making the decisions that they're not making well. But what has produced that data involves the decisions made by humans in the past, right, with all then the lab tests and so the raw data that they're using.
But the model itself is based on the accumulated large, high volume of patient
Yes,
records.
yes, yeah, yes, exactly. Yeah. Well, here's a picture of part of what comes out of the model. So this is if we have the data for a particular patient, that data is now being evaluated by the underlying model based on the accumulated experience from thousands of other patients. The question is, how does your particular patient look like thousands of other patients that we know what happened when they were discharged? Does your patient today look like other patients who were discharged on a particular day and it turned out to be successful or unsuccessful? So what we get out of the model is something that's been completely unavailable to anybody making this decision, is predictions of readmission probability that vary by day as the medical records are updated. So the center jagged line are the point predictions of probability of readmission. The outer dashed ones are the 80% confidence intervals. So we're going to see later how this is part of what ends up being in the interface, but a lot more ends up being with the interface than this. But this is what one of the central things the model is producing.
So just a clarification. So back to that picture. So if I'm the physician and you're the patient, on day 0 when I'm thinking about whether to discharge you or not, if I understood you right, you're showing me essentially something like this graph right here, projecting out to give me some horizon for what I think, and then it's just going to be.
No, not for what you think. If you were making this decision to discharge this patient on day 4, see on the horizontal axis, day 4, you would only see the part of that chart up to day 4 because the rest of that data for your patient doesn't exist yet.
Oh, okay, so I wasn't sure if the future days have.
Can't be,
Got
because
it.
you don't have that data on your patient yet.
Right, okay.
Yeah. So you'll see, on day 4, you'd see the part of the chart up to day 4, nothing beyond that.
Got it.
Yeah.
So this is a prediction for an individual.
An individual patient. Yeah.
So the
Based on the accumulated experience from thousands of patients.
So some of them are going up over time because bad things have happened to this individual. While they've been here, all of a sudden I'm getting signals that they've got problems they're going to.
Yeah, this one is pretty much going down over time, but they don't all look like that, of
The
course.
first when you showed me this, I just thought you were telling me the longer I stayed in the hospital, the less likely I was to ever come back, or to come back in the 30 days. That's not what this is.
Well, that for this particular patient, that's true. On the other hand, the longer this patient stays in the hospital, the higher and higher and higher costs you
Right.
get. So the question is, what point, do you discharge this patient on day 4, once you have that 4 days data? Do you discharge them on day 8, or do you keep until day 12 or longer? Now the point estimate, by the horizontal line is the target readmission probability, which is not 0. No, that's like saying the unemployment rate should be target rate should be 0, right? It's not 0, and it varies by diagnosis code. So in this case, for this particular patient, the point estimate crosses over the 0.2 target rate in day 6. The conservative use of the model would say you look at the upper percent of the 80% error bound, which is 10% error on the side of this that counts. That conservatives say you discharge them in day 11. Yeah.
So just following with Jim's question, if you were in day 4, you would not know that it's in day 6 when the point prediction crosses.
No, that's what I just said.
Yeah.
I'm showing you this whole thing, but you can't possibly know. I've just showed it to you to show what it looks like over a whole time. But you can only possibly see the part of this chart up to the day in which you're making a decision. So if you're making the decision on day 4, the only part of this chart you see is that part up to day 4. The rest of it doesn't exist yet. Can't possibly exist.
Well, but I mean, you're tracking what's essentially a state variable, right? I mean, the longer someone stays in, you could, in theory, be able to estimate some sort of state evolution, which you could then predict out if you wanted to, and say, oh, here's my state time series equation, and this is how people's statistics have evolved over time. I could just plug in where I'm at now. I could get some forecast of what they are, and then get a point prediction.
Yeah, but you don't want to do that. And the reason you don't want to do that is because the way the patient data can change. So suppose you have a surgery patient, and for the first 4 days, it looks like this chart. And then on day 5, all of a sudden, you find out that their white blood cell count has just shot up, and their temperature just shot up, and these are surgery patients, you just found out that the patient has an infection. Okay, and you can't know when that sort of data might come in. Anything else on this? Okay. Okay, so the CDSS, it uses time-varying predictive model to make recommendations. The target discharge rates, we're trying to implement a Medicare target. We're trying to implement a 10% reduction in historical readmission rates. That does not lead to, that does not cause you to have to keep the patients much longer and inflate costs. So that's the way this is set up. So our target rates, in this case this horizontal line, are not historic rates, they're 10% below historic rates. Recommendation. Yeah, if the point estimate is above the target, the recommendation is do not discharge, coming out of our CDSS, of course, the recommendation. If point estimate is below the target, but 80% CI is not, our recommendation is physician judgment. If the upper 80% CI is below target, the recommendation is discharge. The CDSS also graphically illustrates additional information time-varying probability of prediction, of course, up to the present day. And it also dynamically selects 6 panels of key variables. And the particular variables can change from day to day based on the changing information for that patient and how the underlying model is processing that. But it displays those 6 key panels of data with time trends and normal ranges. And it is embedded in a standard Cerner EMR interface. So it's designed to be brought into the EMR in a hospital. Okay. The experimental design. In the baseline, the subjects get patient information in a facsimile of Cerner's EMR screens. In other words, in the baseline, they get exactly the same data that they would get if they were on a hospital ward in Emory University Hospital from the hospital's EMR. They wouldn't, of course, in a lab experiment, they're not also examining the patient in these, although we have a later lab experiment where we brought that into it, having an experiment run with what are called standardized patients, which is part of medical school education, is that you have actors who come in and play patients. They're probably not very good actors, so they wouldn't have that job, but they play patients because, you obviously you don't want to have students that go through medical school and then read textbooks, take exams, and then you throw them in with patients. So they have 2 types of labs, at least at Emory. One of them is dummies that display vital signs, just like on a television program where you see the patterns, and another one where the humans. We've also done an experiment with that. Not talking about that today. Okay, so there's the baseline where they see the EMR screens. In the information treatments, the subjects get patient information in Cerner Facsimile EMR screens just as in the baseline, but then they get the information from our CDSS with decision recommendations, probabilities, and 6 key variables. In the default treatment, everything is the same as the information treatment, but the default option is changed from opt-in to opt-out. Now, the standard one is opt-in, which means if you're in a hospital, in order for you to be discharged that day, the physician with authority to discharge you, first of all, has to show up that day, and then they have to, they're going to examine you and look at EMR, and then they have to fill out discharge orders. So it's opt-in to filling out the discharge orders. We are bringing something here, obviously, from behavioral economics. We're changing the default option so that now, at least experimentally, the patient will be discharged according to the software's recommendation unless the subject overrides that and enters reasons why. Now, in terms of a hospital ward, the physician, of course, has to have the ultimate authority. The way you would implement that on a hospital ward is that you simply change the procedure so that if the physician, if the recommendation is do not discharge, then in order to get to the page in the system where the physician would fill out the discharge orders if they don't accept it, they would have to, first of all, have to explain their reasons. And you see what's going on here. It forces them to go back and look at what the software is recommending and why.
How amenable are doctors to essentially this shift, right? Because it's taken a little bit of power away from them.
Well, that's a good question, and that we won't find out until we get out into the hospital wards. If we can get out on Emory's hospital, GI hospital wards, then I've been assured by my co-author that we will get cooperation there because it's his unit.
Okay. Oh, all right.
So, yeah.
How do you get them? How do you set it up so that it will discharge the patient as a default option? Does it just immediately flow into the discharge screen and all the documents?
In the experiment or on the hospital ward? In the experiment, they're just discharged.
Okay.
Yeah,
On the hospital
but
ward?
on a hospital ward, as I said, you'd have to have that the doctor would still have to fill out the discharge orders.
I'm talking about where the default is to discharge. how do you coerce the doctor to actually sign the paper, as opposed to saying?
You can't coerce them. If the software says the patient should be discharged and the physician disagrees, then the physician can, of course, still discharge the patient. But in order to get to the page where you would fill out the discharge orders, it has to go through an intervening page that provides reasons why you're not following the recommendation.
I agree with that scenario, no problems there. I'm talking about how do you get the doctor to discharge the patient on day 6 instead of holding the patient for another 3 days? So the reverse scenario. I agree that if the doctor has
They still have to fill out. They still have to fill out the.
But they would have to fill it out on day 7, right? So what's to prevent the doctor from saying, I don't think this patient should be discharged. I'm going to come back tomorrow.
Because they again would have to get to you. You would have to have another part of the discharge order screen that would say you would have to fill it out in either case. In this case, you're filling out not a discharge order, you're filling out another part of an expanded screen that's like, the patient is not going to be discharged today.
Right. And how do you convince the doctor to actually, because correct me if I'm wrong, if the doctor says, I don't want to discharge this patient, and they just leave,
Okay.
the patient can't be discharged.
That's true. So you have to have a unit, in this case it would be a surgical unit, where it became part of their standard operating procedure that they needed to proceed in this way. And these are easily doable these days. I know I get my health care from Emory Healthcare, and Emory Healthcare overlaps with the University Hospital. There, believe me, I know from just being in some of my physicians' offices that they can be forced to use the software because they are fairly regularly grumbling about it when you're in there, because they're typing on their laptops while you're in their office, because the organization has told them that they've got to use these systems. So these things are very much enforceable.
Was this just did I miss it just in a GI surgery unit? I missed,
The patients in this data set are all GI surgery patients. Now that we've gone and further in the econometric work, we now have a patient database of over 20,000, and their general surgery, which includes GI, vascular surgery, and lots of other. And we're trying to, of course, to get cardiac patients and so on and so forth. But all this stuff takes unbelievable amount of time. You think regular universities, can be heavily bureaucratized, and medical school is going to be even worse. So.
And so do you imagine there'll be different models based on this is a model based on all the GI data we have. This is a slightly different model based on if they come in with congestive heart failure.
Yes. This we fully anticipate this. We fully anticipate that what we're developing is a procedure to develop these things. But it can indeed be that for different types of patients, cardiac patients as opposed to GI surgery patients, that the underlying econometric model will have a lot in similar, but it can be a somewhat different model, which will be then reflected. But the same process of constructing the model is the same. You may have to calibrate it for different mixes of diagnosis codes, be calibrated differently, and also calibrated differently for different hospitals. But once the procedure is developed, it's just a matter of getting the data. You can calibrate it for a particular type of patient at a particular hospital if you need to. This is why we're looking for partner hospitals. So okay.
You
All right.
answered my question.
Okay. Okay. Experimental design is 3x2. One case, there's a limit of 45 experimental days for discharging patients, a capacity constraint. In the other case, there's no limit. What this is a way in a laboratory experiment of increasing, bringing in bed capacity in a hospital. Since there's pretty good data now that, actually quite good data now, that shows that readmission rates spike when a hospital is at its capacity, because you just think you're a doctor and the word is out. All our beds are full. We got to get some of these patients out of here so we can bring new ones in. And so patients are discharged earlier, and that leads to higher readmission rates. So this is, in the experiment, the way we can bring that sort of pressure to bear. Okay.
Can you clarify what the design again now? Because there's a limit or not a limit. That's one dimension, right?
Yeah.
There's the default option, which is a dimension, either opt-in or either they are held or they are automatically discharged, or the default is the discharge.
Yeah.
And then, so that's the second dimension.
Mm-hmm.
And then there was another.
Information.
The information.
They get all the information, except they don't get the recommendation. They don't. We haven't reversed the default option. So there's two, and then there's baseline.
So the 3 in the 3x2 design is the opt-in, opt-out.
The 3 is one is baseline. They only get the EMR information. In the information treatment, they get our CDSS, but the default option has not been reversed. And then the last one is where we change the default option.
All right.
Okay. Facsimiles of EMR screens are the only screens used in the baseline. And those screens are used along with screens from the decision support software in the information treatment and the default treatment. Here are some examples. So if you were a patient in Emory University Hospital, your physician would be looking at charts that look like this. In this case, the top 2 rows, this one and part of the information here have to do with our experiment. Everything else is exactly what it would look like in the hospital. Obviously, experiment day 6 and so on is part of our experiment. In this case, the patient named Jane Doe, yeah, so not a real name, patient ID. The rest of the information there is actual information from the electronic medical records. So this was a 37-year-old female. You see the other information. Reason for visit, cholecystem, whatever it is. White female came in through the emergency room. Hospital Emory, because Emory has several hospitals. This is Emory University Hospital. Not readmitted. Patient didn't die. And you say the 37-year-old female was admitted through the emergency room with gallstone pancreatitis. She underwent a laparoscopic cholecystectomy and is now 1 day post-surgery. So this is one of your physicians would see this information. Comorbidities, problems, diabetes, no. Cancer, no. Hypertension, no. Alcohol, no. You see day 1 and their GI patients. So of course, an important part of the data as you go along is stool count. Here you see, these are lab test data. Lots of different things there. I want to spend time trying to explain which each of those are. Here we have orders, and this tells you what the physician in charge has ordered up to a certain point. NPO means it's Latin. It means nothing by mouth. So vital sign frequency. So this is all the orders that the physician in charge has given. And then vital signs, and you know what those are, of course, blood pressure, heart rate, body mass index, and pain score, respiratory rate. Okay, So those are what's used in the baseline, which is what people would see in the hospital. Sure.
So one more question for you. In terms of, so for an individual subject as they're processing through this, are they making, like, with these screens, are they dealing with a single patient over the course of multiple days deciding when to discharge and then go into the next patient? Or are they, like, day one you have 20 patients to deal with?
You have whatever your patient load is, and you'll look at this information on each and every patient.
So you're looking at each, so you're going through day one, looking at all your patients, going to day two, looking at all your patients?
Well, the days will be different by one patient may be in day 1, another patient in day 8.
Got it, okay.
And what you're seeing here, since there's not much data, these screens are all early in the visit of these particular patients.
And
There's
if I
not
deal
many
with this
dates data
female-
yet.
If I deal with this 37-year-old female and don't discharge her, do I then see her on day 2 with new vitals?
Yes, yeah.
Okay.
Yeah, so this is what I said. This is what you see here. You get this is only day 1 information. So on day 2, you'll see a whole another set of columns to the right of the day 1s, and you'll see them both, all of that. And similarly for all of these vital signs, this is only 1 day.
But I'm just asking within, I mean, I know doctors would normally do that, but within the experiment, if I am the doctor who's looking at this case,
Yep.
and I choose not to discharge, I would then learn about what happened to her on day 2.
Oh yeah, everything is dynamically updated.
What happens if I say to keep this person and they've been jettisoned out? I mean, in reality, they were actually discharged, so therefore, because you're looking at actual medical records, right?
Yeah. Oh, I think you're getting a little bit ahead of the game. I think you're saying is, what if a subject in the experiment keeps a patient longer than they were actually kept in the hospital? Is that your question?
Yes.
Okay. Yeah, we had to solve that problem. And so what we had to do was construct continuation days for the charts. And this is a case where the continuation days were based on looking at the huge sample and seeing what continuation days of patients that looked like yours that were kept longer. And of course, this is a case where we very much depended on the judgment of our distinguished medical colleague to help us construct the continuation days, but absolutely essential, yes. Yeah.
I'm sorry, you probably mentioned it already, but can you talk about the subjects or the subjects' positions?
I will. Yeah, definitely will. Okay. So that's the information they get in the baseline, but of course it'll be updated as you go from day to day. Every time if you go from day 1 and get day 2, you get twice the number of columns on every one of those. On day 3, you've got 3 times the number of columns, dynamically updated. Okay, so here's the type of information now that we give physicians. They don't have anything like this now in making these decisions. All they have is this stuff. Okay, so what you see here is on the left-hand side of the screen is the information coming out of the decision support, one type of information coming out of the decision support software. And what you have here for patient Linda Doe, we have data up through date 8, and there are point estimates of readmission probability varying by day, and the vertical dashed lines are the 80% error bounds. Yeah.
Okay, I'm a statistician, not an economist. So I just want to clarify a little bit the point estimate here and also the confidence interval is for population mean, right?
Population mean?
Yes, the point estimate from model that is estimate the population mean probability of readmission. It is not for any individual patient.
No. The underlying model gives you marginal probabilities.
Yes, the marginal
with
probability is estimated population mean parameter.
Yes.
Okay.
Because we have to because we're trying to inform your decision about individual patients based on what's been learned from experience with patients in the past. Yes.
But the point estimate here is for population mean, so I think it may be important to also show on the screen that the estimated point, estimated probability of readmission and also the confidence interval is for population mean parameter, not for this individual patient.
It is.
So if
No. But we're asking. The underlying model says it's being used, and it says, how does your patient compare to the population of patients? And so there'll be ways in which your patient looks very much like the mean patient, and others ways in which your patient looks quite different.
So actually, in statistics, the interpretation of this probability is consider that you observe a large population of a patient which have exactly the same characteristic of this patient. Then average of a large population patient with the same characteristics will have the probability of readmission.
Yeah, this is why we're going to larger and larger underlying databases.
Yeah, so this may be helpful to show the information to the physician that this point estimation is not exactly for this particular patient. It is the mean probability of readmission for a large group of patients which have the same characteristic as
Yeah,
this.
that's what we want. That's exactly what we want. It's exactly what we're doing. That's exactly what we want to do.
So I think this may be helpful to show on the screen those information to the physician.
Are you wanting a label on there?
Yeah, label on this tell the physician that this point estimate is mean of probability of readmission for a large group of patients which has similar characteristics as this one. Label this information on the screen may be more helpful.
With physicians, I'm not so sure.
As long as they're educated
Is this
upfront
a
about what this
predictive
is,
value?
that they should know.
Yeah, I mean, they would, when you implement this in the patient ward, they would have to have a training program about what this is giving them.
Okay.
But what we want to do is exactly that,
Yeah.
saying in all these previous many thousands of cases, patients that looked like yours today, this is what the experience was with them. That's what we want to do.
So we have assumptions here that those physicians have received enough statistical training to interpret the results appropriately.
I wouldn't assume that, because this is the way they should interpret this as saying this is giving information based on a large population of patients that I should bring to bear on my patient. Yeah,
So, I mean,
that's the
just-
way they should look at it.
Just as a statistician, we always have this kind of concern of people mistakenly interpret statistical results. So if we think the assumption of physician have received enough statistical education to interpret this result appropriately, that should be fine.
Tim, what would be a misinterpretation? What would that look like?
The misinterpretation is people sometimes believe the estimated probability of readmission is for this individual person.
It is.
So it
This
is.
is not for
So
this
it's
individual.
thi-
This is a mean of large
predicted
population
probability.
which have exactly same characteristic of this
This is-
person.
But that is a prediction.
That's a prediction. That is
Yeah.
a population mean. It's not for this individual. So
That's
what
all
we
you can
want
do.
is the prediction interval will be much larger than the confidence interval for individual patient.
In the interest of time, I think that we should move on and maybe
Yeah.
hash
So-
this out after the seminar.
Did you find a lot of I guess this conversation is getting me thinking, did you find variation between hospitals in the prediction? So if you compared, let's say Emory compared, I don't know if you had Grady's hospitals data,
These are all Emory patients.
all Emory patients.
We're still trying to get cooperation from other hospitals.
Oh, okay.
The other thing that's being displayed here are the 6 clinical variables that the underlying model says are ones that you should pay most attention to for this patient today. And these, again, all of this is dynamically updated. This is the information that you'd have up to day 8. Before that, of course, you'd have less information. After that, you'll get more information on this patient, Linda Doe. And the recommendation down in the bottom left is do not discharge patient. In the experiment, you enter your decision by clicking on one of the buttons on the bottom right, discharge patient or do not discharge patient. Now, of course, you do not have to be a medical doctor to see why the underlying model was saying do not discharge this patient, especially if you recognize that the model is not only looking at when variables are inside or outside normal ranges, but how long they've been inside or outside. You look at YBC is white blood cell count. These are surgery patients, so that's an indicator that you have an infection. So one doesn't need to be a medical doctor to know you got to be very careful about discharging that patient. Yeah.
So you provided them this information. Presumably you have the data to go back and find out which of these factors are most likely to cause doctors to diverge from recommendations?
Oh, that's a whole other part of the research program that I don't know that I'll have time to mention, where we're comparing. We do questionnaires where we ask physicians, what criteria do you use in discharging patients? Then we have econometric model that says what criteria do they actually use, because we can get a measure of that. And then we have this model underlying this one that says what characteristics of patients predict whether the discharge will be successful or not. So we've got a paper now where we're comparing all three of those things.
Well, then you need another paper on what happens when you show doctors that paper and whether or not they change their behavior.
So for this page, it did take me a little bit of time to realize that it's the white blood cell count that's why the system is saying don't discharge.
Yeah. Well, it's that in combination with all the other variables. You also see that the patient is obese from the BMI.
Yeah, but that's not likely to change while they're in hospital unless they're.
Pardon?
That's not likely to change while they're in hospital.
But the fact that the patient is obese means
I don't disagree.
yeah,
So
it's not going to change, but it's important, especially
Yes.
again for surgery patients.
Is there a way to add to this some factor that can make you say, okay, what infection do we think they have? What antibiotics are they on? Because depending on the antibiotics that they're on, that may change my question about whether or not to discharge them.
Oh,
If everything looks normal except for this infection, depending on how under control the infection is, I may still want to discharge them, particularly if I'm in a capacity constraint.
yeah, the underlying database would show.
It's still there.
This is a second screen. I mean, they still have access to the whole. If they presumably if they wanted detailed information on medication history and what else happened. So
They go back here.
That's my question.
yeah, so they
This
they
is
still
also
have, they
available.
Still have all of this.
Okay.
That screen that Jim was just showing is kind of a summary
Just a summary.
of the 6 key points that they think might be most useful.
Mhm.
Is that a fair characterization?
Yeah.
Okay.
So if in fact this patient had, I'm not even sure this is the,
This is a different patient.
this is a different patient. If this patient had an infection, then under orders you would see the antibiotic
Okay.
that had been prescribed. And we're not displacing, we're adding to.
Okay.
We're not displacing their screens, we're adding to them.
Just adding to it.
Right. Okay, so this case of do not discharge. Now, a few days later, we have more information on Linda Doe. Here, we only went to day 8. Now we're up to day. Wait a minute. Yeah, we've gone further into the the days. We see that there was a bump up here. And you see that further back now, associated with that jump in the white blood cell count. Now these estimates are starting to come down. In this case, if you look at the last day in discharge, the point estimate of readmission probability is below the target rate, but the upper part of the 80% error bound is still not up below it. So this is a case where the recommendation would be physician judgment. And again, notice that we've got a different set of clinical variables being displayed on the right because they're being dynamically updated as there's more information coming in, particularly more lab test data coming in. Further into the stay of Linda Doe, we see here a case where the entire 80% airbound is below the target rate. The software recommends discharge patient, and it's still displaying, again, somewhat different, but the 6 variables that this underlying model says are most important on this day. Once we change to the default treatment, then again, they'll still get all the standard EMR screens, and they're going to get all the information they get from the CDS for the information treatment. But in addition, notice that these 2 buttons here, if we look here, there's always the decision buttons in the lower right. It's either discharge or do not discharge. That's true everywhere. Now we've changed to the default option. In this case, we've got Lucy Doe, and we see we've got several days of information on Lucy Doe up to the present day. The point estimate is still above the target rate. Recommendation is do not discharge. You've got the 6 key clinical variables. We see we've got BUN and potassium that are outside the normal range. But now notice the 2 decision rules are, one of them is do not discharge patient, the recommendation. The other is overrule and enter reasons, in which case you would be taken to this screen, and you see things, just check boxes on the left, acceptable lab values, acceptable vital signs, acceptable in and out, it's eating and defecating, acceptable orders, other, and then a way to enter free form comments on the right-hand side of the screen. Here's a recommendation where the software, if it's patient discharge, physician judgment, then there's nothing to overrule, and so that screen wouldn't look different than 2 treatments. If you have a recommendation, discharge patient, you see why the entire error range at the last day on day 11 here is below the target rate. Software says recommends discharge, again selects 6 key clinical variables, and now the 2 decision buttons in the lower right are discharge patient or overrule and enter reasons, in which case you'd go to this screen that says unacceptable, all of these various things, and you can enter free form statements about why you're disagreeing. Okay. So the experimental design, we select 30 patients from the data set, the actual electronic medical records. We don't just do it randomly because we wanted to have patients who were in diagnosis codes where the target readmission rate was high, medium, and low, not all in one category. Otherwise, we would have confined it too much to what the decisions are about. The experimental subjects could see 3 patients in each experimental day. They were paid $5 for each successful discharge, of which there were only 30 possible. If a patient is readmitted in the experiment, they stay in the queue for 2 days. In other words, you can't just immediately discharge them on the next day. It's a 2x3 design. The 2 time constraints I mentioned earlier, 45 experimental days are unlimited, and the 3 information and decision treatments that we've been going through in detail: standard EMR patient data, use of CDS with information, use of CDS with change the default option. At the start date on the seeing electronic medical records, we didn't want to promote, as we all know who are experimentalists here, you don't want to have subjects in an experiment sitting there for a long period of time where there's actually no real decision to be made. So what we did was the first day they would see a patient record in the experiment. It was randomly selected between 1 and 4 days before the first discharge recommendation by the CDSS. Now, of course, we needed to randomize that because we didn't want to build in some artifact where it's, always discharge on day 2. That'll work well, or something like that. So that had to be randomly varied. There were, somebody asked about this earlier, there were 125 subjects. 20 of them were residents at Emory University Hospital, and 105 were fourth-year medical students.
So Jen, the 45-day constraint, so if there was a patient who in principle should have been in the hospital for 50 days, you come to day 45 in the experiment, and that's a patient where the right decision is to just not discharge them and you just don't get any money for that subject?
No. What we mean is that the subjects have 45 experimental days to discharge any patients they're going to discharge. And once they get 45th experimental day, after that the experiment just ends. So it puts them under time pressure to make their decisions. The others had unlimited time, although there was a 2-hour limit that they'd been period they'd been recruited for, but that was never binding. And then there's a post-experiment questionnaire. I already said the resident physicians, medical students, fourth-year medical students. And this focus in this initial case was GI surgery. And what we found was that the use of the CDSS combined with the change in the default option reduces average length of stay and reduces probability of readmission for high-risk patients. So it's, in that sense, lowering costs and increasing quality. Okay. Here's what we, first summary of the data. The readmission rates for all patients, the baseline was 10.21%, information 10.4, default 9.84. The difference between baseline and default is significant. For high-risk patients, it was 13.5, say 12.7, and 10.8. Again, the difference between baseline and default is significant. Length of stay, all patients, you see with the baseline, 7.72, information 7.15, default 6.64, high risk 9.24, information 8.53, default 8.12 for length of stay. Here are probate regressions for readmissions. And we look separately at all patients in the right-hand column and high-risk patients in the middle column. And yes, recommended length of stay is significant for all patients. Understay or overstay means understay or overstay relative to the recommendation of the software. And we see that for all patients, subjects who had kept the patient fewer days than recommended by the software had significantly higher readmission rates. Interestingly, if you look in the next column, overstay does not lower readmissions. So it only adds to costs, but in the experiment at least it did not lead to further reduction in readmission rates. So just keeping them longer and longer is adding to costs, but not increasing quality. I'll look further down to the default column. So here, we see that is significant for the default treatment for high-risk patients, but not for all patients. And we get now further down into the table, we get into some demographic and other kind of data. We see we get significant reductions for both high-risk patients and all patients for the category of subject called musical. And there's another one further down that should be, oh, just above that for athlete. You might wonder why that's in there. The medical schools in general, but most especially acceptance into the surgical specialty, they select for students who either have a background as being serious musicians or athletes. So for example, the John Sweeney, my co-author, as an undergraduate was a starting fullback on the Notre Dame football team. One of the people we're working with in the transplant surgeon, Nicole Surgeon, was a NCAA gymnast as an undergraduate. Another transplant surgeon is a very skilled musician. You might wonder, what's that got to do with it? Well, think about it. If you're an undergraduate and you're in a pre-med major, that major is very competitive and very demanding. And if you also are a competitive intercollegiate athlete or you're a serious musician, you're doing something else that demands a lot of self-discipline and a lot of your time. So that's why they're selecting for those. They're very good predictors of success in the surgical specialty. Yeah, and we're finding that, at least for the musicians, coming through as significant, but not the athletes in this case. So I, of course, had some jokes with my collaborator and friend John Sweeney about that. You did all that stuff playing on the football team, and it just doesn't improve your. So we have fun with that. Okay. Also, there's a risk aversion that comes through as significant, and of course the target probability does. Notice that the 45-day constraint comes through as significant, quite significant, so yes, when, just as has been observed in field data in our experiment, when we put the decision makers under time pressure, because of you've got to get these patients out of here quickly, it increases readmissions in the experiment, just as it does in the field data on hospitals. So if you're going to go into, if you have an elective surgery, find out how crowded the hospital is before you agree to do it, because you don't want to go in when it's crowded.
For the risk aversion, are these risk takers or are they more risk averse?
The more risk averse. So this means the risk aversion, more risk averse. No, this is the case where the more risk averse subjects are having the less risk averse subjects are having more readmissions.
You mentioned earlier that the doctors typically make these decisions based on their experience and their medical training.
Correct.
You don't see any difference between residents and medical students.
That's right.
Do you think if you introduce doctors into this mix, there would be a difference in their experience or the kind of decisions they might make relative to maybe students or residents?
Could be, yeah. You can imagine the problems we had in recruiting subjects. We were lucky to get some residents, and we weren't going to get any, I think, of the heads of surgery units and things. But yeah, point well taken.
Just a little bit of comment here is recently in the statistics community, there are increasing criticism of building such a precise prediction model based on big data. The reason why is, according to the recent research, because the real-world data can only include finite information. It is due to the fact that the real-world data always measured at some finite precision. It is not really continuous measure. So therefore, the real-world data always contain only finite information. As a result of that, the precise model built based on large data will have the largest possible model error instead of data error. So there is increasing criticism within the statistics community, which is against building such precise model based on big data. Instead, I have done two projects similar as this one, building the analytic model, making prediction based on patient record. So the final outcome from the model I built is only those group of patients may be discharged. That group of patients may not be discharged. So we do not estimate the precise point probability of the patient should be discharged or not.
And
so
you do,
this is our
you don't do this
experience
because of
within
why?
Our community.
And you don't do estimate probabilities
No,
based
we
on
just,
why? So you would just give up on the whole project like this?
We just identified that this group of patients may be discharged, and that group of patients may not be
Okay,
discharged.
that'd be completely useless to apply on a hospital ward.
The other thing here is we try not to make this precise point estimated probability.
Okay,
of,
but here's how we evaluate this, and this is what's done in medical journals, in the medical literature. So so here's how we evaluate these models. There's something called C-statistics, and this is what you use in medical journals, something that most economists don't know about. But what they are measuring is something that we are familiar with, which is in-sample and out-of-sample predictive accuracy. The model here that underlies this, we have a within sample C-statistic of 0.8, out-of-sample of 0.7. Now that we have larger data set, we've gone up to 20,000. We've got C-statistics both in sample and out of sample that are above 0.8. And what in the medical literature is considered good performance is anything above 0.7. So by those measures that's used in the medical literature, we're using this large sample of data in a way that's, by the way they judge it, is highly successful application. This is the way the medical literature approaches that question. But let me talk more about what's in the paper,
So
and we can have a detailed
This
conversation.
is kind of a point of argument going on right now between a lot of people. So.
Okay, maybe lots of people, it's not in the medical literature. But why don't we talk about this later, because this is way off
Yeah,
topic.
I know. It's
We are
just-
applying the accepted standards in the medical literature to judging in-sample and out-of-sample predictive accuracy. Okay, and it's out-of-sample predictive accuracy that we're really, really concerned with, and we're doing really, really well compared to the standards in the medical literature. Okay. The censored regressions for length of stay. Again, we're looking at high-risk patients and all patients separately. The recommended length of stay, of course, that's going to be significant. Now, if we look for treatment effects, we see that for high-risk patients, the default treatment is highly significant in reducing length of stay. For all patients, also, that this is 1%, and for the high-risk patients, that's 5%, of course. Other interesting results we're getting differences between female doctors and male doctors, where the female doctors are keeping their patients longer. Nothing significant again for athletes. Musical patients are keeping their patients longer, and we're not getting anything for various GPAs, but one of the things in the paper we showed that we had to have a very, very, very good distribution of patients across the different treatments. So the male, female, and residents versus students and so on. It's all kinds of tests where they were not getting any possible problem that we could get from having a different mix of types of subjects in one treatment rather than another. One thing we see down here at the bottom is that for length of stay, the resident physicians are keeping their patients longer than are the medical students. As it turns out, for other things, we find for here, we see that they don't have lower readmissions. So relative to the students in this particular experiment, the residents are adding to costs, but they're not improving quality compared to the fourth-year medical students. This could have been that the residents were more resistant to using the CDSS. But we're going to see some other things about that. Okay, in terms of the capacity constraint, or the 45-day constraint, here these are kernel densities, and what we see is that the 45-day constraint simply pushes the distribution to the right relative to no constraint. So it's just produced worse decision making. And again, we all understand how time constraint can lead to worse decision making. Okay. Our general findings: use of the alpha CDSS with a change in the default option reduces average length of stay, reduces probability of readmission for high-risk patients, and of course doesn't increase it for other patients. These results imply, if they carried over and we got the same pattern on the patient wards, would imply a sizable reduction in hospital costs and either higher quality or no reduction in quality. Subsequent steps: we experiment with bundled and bonus versus fee-for-service payments, because bundled and bonus payments are the next thing that Medicare is pushing. So if you think about what's in this paper, in some sense, and what we're looking at now, what Medicare sees the problem as now. Medicare now sees the problem with excess unplanned readmissions. But in some sense, as is in many areas of public policy, what is now seen as the problem is a predictable outcome from the solution to what used to be the problem. What used to be the problem was everything was fee-for-service, and so the longer you kept a patient in the hospital, the more money you made. The more money everybody made, the hospital, the physicians, so on and so forth. So quite a few years back now, Medicare put in a plan that says, no. A patient is admitted under a certain diagnosis code, and once that is done, then the hospital gets paid the same amount, no matter whether the patient stays 2 days, 2 weeks, or 2 months. Now, we economists can predict what's going to happen with that. Patients are going to be kept longer, in which case the next problem will be excess readmission rates. So this is true of public policy all over the place. So this is a particular manifestation of that. But the next thing that's coming down, and it's just starting to be implemented now, is, I think about now, the incentives for the physicians are, it depends on the type of physician and whether they're lined up with a hospital or not. So surgeons, this is surgical data, surgeons get paid a certain amount for doing a particular type of surgery on a patient. And if they continue to have to provide service for that patient for 2 days, 2 weeks, or 2 months, they can't charge anything more. Their incentives are lined up with the hospitals. All the other patients and specialists they may call in, the anesthesiologists, the oncologists. So you're doing, my colleague is doing GI surgery, and he got somebody cut open, and what he finds is, oh, I think I need an oncologist to call in. Okay, the oncologist comes in, somebody else you have to pay, and all the additional people that are called in, a lot of them are still on fee for service. So the next stage here is to bring in what are called bundled payments, so that a patient who comes to, say, Emory University Hospital, who is admitted for some type of GI surgery, that patient is admitted, the total payment made by Medicare would be a fixed amount for everybody. And of course, the insurance companies always follow Medicare. Once Medicare does, they follow them. And so that now, we economists immediately know what's going to happen now, is now you've got to have all kinds of things going on within the organization, because you've got to find out some way of solving this problem of the different financial incentives, as well as professional incentives, of course, between the different groups. Now, of course, what I would want is if we have a general unit now under the system, and if just think about the existing system, and we're physicians, we're operating under it, and we know that not always, but because it could get a hospital-acquired infection or something, but very often if you keep a patient longer, the readmission probability is going to be lower. But we might get fined by Medicare. Okay, so it's clear what I want to do. I want Kerry to discharge his patients really early. And I keep mine longer because my patients do better and he solves our problem with Medicare. So you've already got an internal diseconomy amongst. Now, once you start to bring in bundled payments, you just got that whole problem in spades, because now you've got the hospital involved, and you've got all, not only the primary care physician, say the surgeon, but you've got all the anesthesiologists, the oncologists, and all these other people that are all have got to work out how they are going to organize themselves to divide up this fixed chunk of money. Anyway, that's in process. So this other paper that I mentioned is also in press, is one where we conducted a similar experiment, but we're out in front of the curve here now. We're experimenting and comparing two different types of bundled payments. We call bundled and bonus. We're comparing that with fee for service in making hospital discharge decisions. That's the second paper. Working currently in process, we're re-estimating the model with larger sample and more patient codes, and that is also a paper that's finished. It's in press. We've got an experiment that we did with patient actors. The experiment is conducted. The paper isn't written, and this is a case where we were experimentally examining the following sorts of issues. If you create a CDSS, there are two types of problems you can run into each other, and they're quite different. It can be that people become overly reliant on medical software, reliant on it. And so the patient, if they examine, can actually be giving some signs that are, if they're paying attention, could be giving them, pointing them in a different direction than is decision software. In particular, for example, it could be that the last time they did the lab test for a white blood cell count, and the nurses took the temperature, that those things are going to, especially the lab test is going to be delayed coming in, and maybe the last time that they took the temperature was 4 or 8 hours before, and you examine the patient is reporting something that's indicating that, I'm not feeling so well. I was feeling better, and I'm starting to feel a little bad, and the patient might be indicating something that says, hey, wait a minute, the software is telling me discharge, but the patient is giving me information that doesn't seem to be entirely consistent with that. So you can be overly reliant on software, and this is well known to happen for different kinds of software than this. The other kind of problem you can run into is physicians don't want to use it. So one way to think of it is obviously an oversimplification. It might be the young doctors just out of medical school might be more inclined to be over-reliant on the software. And the crusty old guys, since I've been making discharge decisions for 30 years, I'm not about to need anything like this, and I'm just not going to want to pay attention to it. So there are two types of dangers. Now, one of the things we did experimentally was try to check on the overly dependent one. And here's the way we did this experiment. I mentioned very briefly before. So as part of medical school education, you have what are called standardized patients. Like this, maybe otherwise unemployed actors. They come in, and they have all the examining rooms, and the medical students, fourth-year medical students, they go around and they interact with the actors. They develop their bedside manner, but also they're interacting, and the patients have been asked to follow the standardized patients to follow scripts in what they're presenting. So we use that. It's designed as an education facility. We use that as a research facility. And so what we did is we gave randomized, of course, no way we need to, but we gave half of our patients scripts of what they were going to report that was inconsistent with the software's recommendation, and the other half that were consistent with it, to try and see whether at least young doctors would be inclined to be too dependent on the software, or just the opposite, perhaps ignore it and only pay attention to the standardized patients. So we've done that experiment. We haven't written the paper up. Developing the beta version of CDSS, that's beginning. Patient-warned intervention is at the planning stage, but those are the cases where we've just been stalled because we now need cooperation from an IT department at a hospital and from electronic medical records company, and that's a problem that is extremely difficult to solve. Even when they say they're interested, they're always, especially the IT departments at hospitals, always seem to be in crisis mode, in particular because they're introducing electronic medical record systems, then they're extending that to patient portals so the patients can log in and just see all their own lab tests and so on and so forth. And now Medicare, the government is, I think Medicare is now changing to a new diagnosis code system. So now all of the IT departments are going into a new crisis to switch over to that. So you can see the type of problem we have to try and solve to actually get out onto the patient wards, even though this is such an important problem to them now that they're being fined substantial amounts by Medicare. It's not only the fine, it also damages their reputation. So that's where we are.
How dynamic is everything going on that you would need a dynamic model in this way? I mean, how much do you expect things to change over time such that you would need to constantly be entering new information?
Well, the thing is now, of course, what we've got is a model that can handle what is a record that came out of some of these electronic medical records, and we're introducing, we estimate it, but then when we use it in the decision support, we of course introduce information for that individual patient one day at a time, one experimental day at a time. But we've what we've got to do to do this next step is, first of all, we've got to get our server inside the hospital's firewall. Now that in itself is, of course, you can imagine, that is difficult to get them to agree to. We think we've done that in Emory. What we've got to have, and we thought they would never agree to this, but in principle they have, we need two-way communication between our server and the EMR server, because they've got to feed us out the data as it's coming in. Every time new lab tests come in, and this is with a lot of patients, so we've got to get that information coming in into our model, update the model, and then send that updated recommendations back to the EMR. That would be what we do first. The next stage that we really want to get to, and this really ups the ante, is we would like to be able to almost continuously update our model. Now, the way we'd apply it first would be we would estimate the model given the EMR sample from a particular hospital, types of patients where it's being used, and then update it discontinuously. So maybe every month, every 2 months or something. What we'd like to do in the final version of this would be able to just update it essentially continuously. And that really, really ups it.
But why do you need such updated information integrated into the model in real time? Are your predictions really going to change that much day to day or week to week, where you couldn't just do this every 5 years, for example, using new information?
Not every 5 years. And we certainly don't need to do it continuously. Updating it once a month, once every 2 months. Do I know we need to do that? No. but I don't know that we don't need to do it. And so I
Sounds
think,
hard. So
Yeah,
I'm trying
I
to
think
give
we
you an
need
out.
to. But the things can change reasonably quickly, especially if we've got some new problem with comorbidities. So if you have something like a new particularly virulent strand of influenza that is hitting a bunch of your patients, that could lead to problems if you calibrated a model and hadn't used that information, and things like that.
Okay.
I don't know who was first.
I can't remember if you mentioned it earlier, but how did you decide on an 80% confidence interval as the decision rule for the discharge or not?
We thought that a 10%, it's only one side where that matters.
Right, yeah.
10% error rate was a reasonable one. But again, of course, that's just a calibration of the model. Any particular hospital, they said they want it to be 5%, 15% or whatever, that's easy to reset. We thought a 10% error rate was pretty conservative, especially given that some of the planned readmission rates are, depending on the diagnosis code, they vary between about 5% and 20%.
But in theory, you'd imagine there's an optimal one, right? I'm not suggesting that you could actually conduct experiments actually varying what that upper confidence interval is, but in theory there should be an optimal one. Is
Yes.
there? Yeah.
Yeah.
I'm just trying to think of.
But we just selected it on pretty
Yeah.
informal reasoning. It seemed like a reasonable thing to do. And the medical practitioners that have seen this have all, but I'm not sure whether their opinions on topics like this are all that. Physicians are known to not be very good with statistics.
If you want to get an optimal solution, you have to first define the objective function.
Sure.
So
Yeah.
that
Yeah.
is the
Yeah.
Yeah.
you have to
Right,
first.
yeah, exactly.
I'm just curious, in the whole medical care field, where is it on the sort of spectrum of sort of interest in experimentally testing what happens when you sort of change the way something is done, or introduce new technology and so on, where on the and I'm not an experimentalist, I'm sort of an admirer of experimentalists, but so let's say if you talk about, say, the philosophy, say in education, we teach math using this method, or we teach it using this method. We tend to, before we thought about experiments, it's like we shift the whole country from one textbook to the other instead of doing an experiment to see, which textbook actually works but is more effective. We're sort of shifting half at a time or so on, and we're sort of realizing that that's instructive to do that.
Right.
And where is the medical field on the idea of formally incorporating experiments to see, see what happens when you change a default or things like that? Is this something totally new in its infancy, or are they pretty philosophically far along in that?
Well, the medical profession, of course, regularly conducts all manner of experiments, right, called clinical trials. And of course, drug companies perform experiments all the time, trying to get approval.
But here I'm speaking about experiments with sort of the behavior of.
Yeah. I was getting there.
Okay.
Yeah. So the answer is, as you might lie behind your program. So what you're talking about is, we're talking about providing a tool, a CDSS, that, if it works well, would change behavior of practicing physicians. The medical profession is, as we found out in sending papers to medical journals, they are not at all used to experiments that examine their behavior and possibly into the conclusions about how it should be changed. They are not used to that. But So we have some experience in the resistance to that topic. I mentioned papers we had accepted, a couple in medical journals. I didn't list the ones that they've rejected on the grounds that they refused to look at the nature of the question. But given the pressure that hospitals are in particular under now, they have to start looking for ways to improve performance. In particular, they have to start finding ways to reduce readmissions. And given the capitation payments that just keeping patients longer, on the average at least, can reduce readmissions, it would be extremely costly to them if that's the approach. So given the pressure they're under, we anticipate that eventually we'll be able to get there and be able to get onto the patient wards. But the more general question of trying to improve performance, I think it's pretty generally known that the medical profession can be incredibly resistant to change. But the least resistant parts of it are the university hospitals, and that's where we're working, that's where we're starting. Now, I anticipated, my model, may be wrong, maybe just overly simplified, of the medical profession is that when you, anything that comes out that criticizes what they do, the response is to circle up the wagons, defend what they're doing, and fight off any information that might lead to improvement. And I anticipated that when we first started interacting with medical doctors, but I was completely wrong, because the doctors we're interacting with, these people are like chaired professors at a top medical school. They are practicing doctors, but they are researchers, right? And I have found them completely open. In fact, whenever I say things, and I'm often not really indirect, I say things that are critical or potentially critical of what they're doing, I've found complete openness. They say, we need to improve everything about what we're doing. And they asked us to join them because they saw the possible benefits of working with people with our areas of expertise. And I have found complete openness. Now, I'm also talking about a very high-level university medical school. I'm not talking about the average physician. But that's where we need to start. I found complete openness. So I think in terms of, why can I say, that's how you're making the decisions? Why are you doing that way? What information are you using? How are you going about it? I said, really? And why are you doing that in that way? Don't you think you can do that better? Complete openness because they want to improve what they're doing, and they are willing, in fact, completely open to considering that part of the problem is that they are not going about making their decisions in an optimal way. That's the key. Are they open to even discuss that topic? I have not encountered I have never found a single case where somebody was offended when I raised issues about looking at how they make decisions and how they're using information in doing that. But I'm also dealing with the creme de la creme of the medical profession. Okay. So I think the circling up of the wagons idea of resistance is something that we get mainly when we're looking at something like American Medical Association or something and representing peace. But that's not the people we need. We don't have to deal with them. We have to deal with medical school faculty as the first place to go to look at these questions.
We need to get Jim back to meet with Rashmi, so I'm going to wrap it up. And thanks, Jim. Thank you.
Yeah, thank you.